Hi everybody! Today in pharmacology we are going to be learning about a class of medications that is targeting or replacing the systems in the body naturally associated with the adrenal glands. So when we take this word apart, we're learning again about adrenocorticoids, and the adreno in there is pointing us to the adrenal glands. However, the adrenal glands, as I mentioned very briefly, they have two parts associated with them. They're actually two distinct glands within a gland themselves. They're made up of a cortex and a medulla, and those each have their own job. So adrenocorticoids, cortex is the outermost portion. So this is referring to products made by the adrenal cortex. And then you've probably seen this before, oids, like glucocorticoids are referring to things that resemble something. Whenever you see oid at the end, that means that it resembles either a natural product or a natural response by the body. So adrenocorticoids, if we just take that word apart, gives you the meaning that we are talking about substances that mimic or resemble products of the adrenal cortex naturally. We'll start out in this talk discussing and reviewing, if it's a review, normal adrenal function, including the products of both the cortex and the medulla. And because this lecture is going to focus on the cortical products, we'll review glucocorticoids and mineralocorticoids. And just remember that these substances affect nearly every cell in the body. They just need a glucocorticoid receptor to bind to. Luckily, every tissue in the body has them. What that means for us pharmacologically is we can put these drugs anywhere. Locally, we can inject them, we can put them in a cream, in a spray. There is a wide variety of options available. And we can also give them systemically through tablets or broader types of injectable doses. In the next talk, we'll go over the clinical pharmacology associated with adrenocorticoids. So let's start out with a review of the physiology. So assuming that the individual has I don't want to use the word normal, but let's use typical, the typical amount of kidneys, which is 2, that would indicate there's 2 adrenal glands. And we also refer to these as the suprarenal glands. Supra means above. So the suprarenal glands, they sit atop the kidneys. There is a left kidney and a right kidney, which means there is a left and right adrenal gland. Even though the adrenal glands are small, they are mighty. They have a very large and important job. And again, there are these 2 areas. There's the medulla, or the center portion of the adrenal glands, which is responsible for catecholamine synthesis in mainly the peripheral parts of the body. The brain is able to make its own catecholamines. We'll see that in just a second. And then the adrenal cortex is responsible for things like making mineralocorticoids, which affect things like sodium and potassium balance in the body and other types of electrolytes. You see glucose on here because the various products made by the cortex, one of the main ones is cortisol, and its friends in the body help liberate stores of glucose in times of physiologic stress, which isn't the same as psychological stress, where you might be thinking of something important coming up and you are very anxious. That is definitely a type of physiologic stress, is mental strain. However, physiologic stress refers to any deviation from homeostasis. So it can be temperature based, it can be circadian rhythm based, like a lack of sleep, a lack of calories throughout the day. So cortisol is used for a variety of things in the synthetic form of cortisone or hydrocortisone. And in the body, the end result, the end goal of the release of cortisol is to release the storages of glucose. And then we also have a layer that's going to produce gonadal types of hormones. And we'll see in females that these are going to really be responsible for a large amount of not only libido, but also secondary sexual characteristics. Here we can see the two distinct components of the adrenal glands, the cortex and the medulla. Cortex is Latin for bark, so in any case we see the word cortex or cortical, we're referring to the outward covering portion, like bark covers a tree trunk. The cortex is the covering portion, which is made out of three distinct layers that we can visualize when stained histologically: the mineralocorticoids, glucocorticoids, and adrenal androgens. At the center, we have the medulla, the medullary region, which has cells in it responsible for the production of systemic catecholamines. And the catecholamines refer to dopamine, epinephrine, and norepinephrine. So just a note about the adrenal medulla. You might be familiar with the adrenal medulla in its functionality of making the catecholamines in the peripheral system. However, this lecture is about adrenocorticoids, so when we are talking about any kind of pathology that involves hypertrophy of the adrenals, which would increase their function, or a benign growth of the medulla known as pheochromocytoma, those are things that would also increase levels of catecholamines. But for this lecture, we don't need to worry about this biosynthesis pathway because we are talking, instead of modifications to tyrosine, about modifications to cholesterol in the creation of steroid hormones. So as I just mentioned on the slide prior, products made by the adrenal cortex are steroid hormones, meaning that they are made physiologically by alterations to cholesterol. And cholesterol is a type of watery substance, which means that it is brought into the cell by a process called pinocytosis. And this process involves LDL receptors and HDL receptors, are two different types of cholesterol, which are brought into the cell and then modified in a variety of ways to become the various steroid hormones. One thing to remember about steroid hormones is that they are lipid soluble. Remember that the cell membrane is made up of phospholipids and cholesterol, and things that are soluble or dissolvable in fat, in lipids, are not required then to bind to a specific receptor on the cell surface. Instead, they can easily dissolve through the cell membrane and then gain access to the inner areas of the cell where they can bind to the receptor, generally in the cytoplasm, and then move to the nucleus where they can affect protein production through transcription and translation. So there are a variety of different hormones, and again, they fall into either the glucocorticoid, mineralocorticoid, or androgen families. And that's what you see over here with cholesterol being modified into a variety of these different substances. So over here on the left, what you have are products that exist all throughout the body that are made through alterations to cholesterol. And then on the right, you have specifically the hormones of the adrenal cortex. So you'll see that cholesterol is first modified into a precursor substance called pregnenolone. And then, depending upon which layer of the adrenal cortex we're in, those cells either produce mineralocorticoids like aldosterone, glucocorticoids like cortisol, or androgens, so gonadal hormones like androstenedione. So when we speak about steroids, so medications that are administered to mimic the naturally occurring adrenocorticoid hormones produced by the three layers of the adrenal glands, we're referring to substances that look very similar to the native substance. So our native substance made by the body here is cortisol, and our synthetic substance is cortisone. And I want you to see how these two things are extremely similar. And that is on purpose. So these still have the same steroid backbone. And when we're referring to that backbone, we're talking about 17 carbon atom molecules that are fused into 4 rings. And then depending upon what's attached to those rings, we'll have different steroid hormones. But they all have that backbone, and they are going to essentially mimic really the hormone that naturally occurs. If you remember in biochemistry, you learned that most reactions are reversible. And we see this too. So when we talk about cortisol, for example, the naturally occurring substance, the synthetic substance that mimics it is cortisone. And cortisone is reversibly altered into cortisol as soon as it enters the body. And then vice versa, cortisol can be converted reversibly into cortisone. Various alterations will lead to the formation of aldosterone, which isn't going to affect things like glucose metabolism, but more so the mineralocorticoid effects like electrolyte retention. When we administer synthetic hormones, one thing to keep in mind is the alterations that are possible to the naturally occurring pathway in the body that makes these steroid hormones. In this case, we're dealing with a neuroendocrine axis called the HPA axis, and the HPA stands for hypothalamus, pituitary, and adrenal. In this type of pathway, we have neurons in the brain, in the area of the hypothalamus, producing a hormone. And in the HPA axis, that hormone is corticotropin releasing hormone. And corticotropin releasing hormone binds to specific receptor sites on the anterior pituitary, which stimulate the anterior pituitary to make the next hormone, a very specific one called adrenocorticotropic hormone, ACTH, which stimulates cells in the adrenal cortex to produce their various products. Cortisol is one of those main products, and cortisol works as the negative feedback in this system, meaning when cortisol levels are at homeostatic set points, that sends a message back to the hypothalamus to release, instead of corticotropin releasing hormone, we get corticotropin release inhibiting hormone, which antagonizes receptors on the anterior pituitary and prevents further administration or production, of ACTH. So when we're doing things like giving people synthetic cortisol through cortisone or prednisone, any of those different substances, we are reaching levels that are at or above homeostatic levels. So do keep in mind that these other hormones, CRH and ACTH, would be decreased due to the negative feedback system by the body perceiving that there's adequate levels of that hormone. So we always try to keep that in mind. We want to keep in mind also the start low, go slow administrative protocol for these various things like glucocorticoids. Mineralocorticoids are a little bit different. They're not so much under the control of the hypothalamus. They're mainly under control of stimulation of the renin-angiotensin system, which we'll discuss in a little. When I said in a little, I meant right now. So what you're looking at on this slide is the explanation or schematic of the different ways that we can have activation of this adrenal system. So it can either be through these mediated stressors involving emotions, perceived psychological stress, We can also have activation through the renin-angiotensin system pathway. Either way, we are going to have in the body production of our mineralocorticoids like aldosterone or glucocorticoids like cortisol. So here we're seeing stress, again, some sort of physiologic stress, which includes psychologic distress. Visceral brain is inner brain. Visceral means inner, so the deeper levels of the brain can activate either through the neuronal pathway, meaning the sympathetic nerves, which activate our fight or flight response, stimulating the adrenal medulla to make our peripheral catecholamines, and then we get these typical increases in heart rate and blood pressure, in bronchi diameter, sweating, shivering, all of those things associated with fight or flight. In addition to having those catecholamine effects, we also have stimulation of the renin-angiotensin system pathway. And this begins when there is sympathetic stimulation, norepinephrine release, again from the medullary area of the adrenal glands, and the kidneys themselves have cells that secrete a product called renin. And what renin does is, nothing really itself, but it leads to the production through biochemical alterations, leads to the production of these substances called angiotensin. And angiotensin is a really important substrate in binding to specific receptors, especially in the areas of the renal tubule, that raise the blood pressure by increasing the amount of sodium that's kept in the body by decreasing excretion. And angiotensin 1, angiotensin 2, these are two products that are associated with increase in blood pressure at the level of the kidneys and the various areas like the tubules inside of the kidneys. And also angiotensin can affect the adrenal cortex to start spitting out aldosterone, which is what we call our sodium sparing hormone. And wherever sodium goes, water follows. If sodium's in the bloodstream, then water will move into the bloodstream, the pressure in the vessels goes up, and there we have our physiologic increase in blood pressure. The other thing that is on here is not only can we have direct stimulation of sympathetic nerves through a more physiologic neuronal pathway, we can also have this stimulated through physiologic stress in the psychologic sense. So this perceived stress. And that would be activated through the visceral brain, signaling to the emotional areas known as the limbic system. So that contains areas responsible for fear, for anxiety, and the limbic system has a signaling pathway whereby it can stimulate the hypothalamus and the anterior pituitary through these pathways, these CRF and ACTH pathways, and stimulate the adrenal cortex to start producing cortisol, which, remember, the end result of that is liberating glucose stores, which are stored as glycogen. One of the main reasons you'll see these synthetic substances used, like cortisone, is because of its depression of immune system activity. So these drugs are anti-inflammatory, because of their activity in the arachidonic acid cascade, and they're also suppressive to the immune system. So you'll see them used to suppress immune responses in what we see in autoimmune or other immune alterations that create a pathology. Another thing to remember from physiologic standpoints, especially with side effects of these medications, is that we don't want constant activation naturally of the HPA axis. We really only want its activation when there is a physiologic stress, right? So we don't want constant activation of this system, of this HPA axis, because we'll have a lot of cortisol production. So not only do we get changes to blood pressure, we also get changes to glycogen breakdown into glucose. So you'll see what we call fat maldistribution in a case where there's a lot of cortisol release in things like Cushing's disease. When the glucose is liberated and then not utilized, it'll distribute itself and be stored in some maladaptive places, like in the paraorbital region, in the submandibular region, in the supraclavicular region. So fat maldistribution or between the scapulae is another one that you'll see in these pathology states. So we don't want this constant raise in glucose because of the side effect of fat maldistribution. We also don't want those constant anti-inflammatory immunosuppressive effects, for long term, because we still want to be able to fight infection and fight disease. So we need to think about those side effects in addition to thinking about the stress activated effects of cortisol, where we have changes to the heart rate, to the respiratory rate, and those types of sympathetic things. When there is a constant release or activation of the HPA axis, that actually has a name. It's a disorder. It's called general adaptation syndrome. And this is something that the body engages in when there is a long-term stressor. You may have heard of the studies where they took mothers away from infant monkeys, infant primates, and gave them wire mothers instead. So really, it's brutal to read if you read it now. But what they were doing is instituting a perception of long-term stress. So they were removed from their mother. They didn't have a mother to cling to, a mother to nurse with. So they were raised under highly stressful conditions. And what we saw is this constant overactivation of this HPA axis. And when there is this initial highly stressful event, so picture you hear the fire alarm go off, right? So well, here we go. The fire alarm goes off. That instigates the initial sympathetic response. And we call that initial response the alarm phase. And that alarm phase is usually just a couple of hours long if it's prolonged. So if the fire alarm is going off for 3 hours at once and you've got to evacuate and wait for it, that is really marked by rapid catecholamine release. And that's really going to be predominant for the first couple of days. It takes about 1 to 3 days to reach the next phase called the resistance phase. And this is a phase whereby the tissues stop responding so much to catecholamine. So they become used to their binding and they start to not recognize it anymore. The tissues become insensitive to it. So that instigates the release then of cortisol through that limbic system pathway. So it's not fight or flight, it's prolonged stress. And once we get cortisol and the other corticosteroids into the periphery, we start to see what's called a steady state compensation. The body is providing alternative fuel sources. Instead of the short-term alterations you'll see in sympathetic discharge, the cortisol helps to create this ability to withstand prolonged stressors. And that takes, again, about 1 to 3 days. However, after a while, the body can't handle that. So you get into this exhaustive phase where the body can no longer compensate for these changes, compensate for these long-term stressors. And in these cases, like with the wire mothers, for example, you find that they don't live as long as monkeys not taken from their parents. When people are isolated, when they grow up, without somebody else there, when they're not touched, like these high-term stresses, they don't live as long as animals without those things. We see this all the time with animals in captivity, especially like in a zoo or something of that nature. They're outside of their typical environment. Maybe their circadian rhythm is off. They're not used to being around people who maybe knock on the windows all of the time. And you can see that they're in distress. They've got pupil changes. Their hair stands up on end. They're exhibiting this sympathetic discharge. And the body tries to compensate by additionally releasing glucose so that there's extra energy for the body to run at this really, really high rate. But the body can't do that forever. And eventually, an exhaustive capacity is reached, and that leads to death. And this happens, and it is a reason why we want to think about the dosing. If we are giving a really, really high dose of a synthetic cortisol, then we're going to have these long-term effects. And we don't want to see long-term effects to the tissues, to the physiology, and to the general, health and well-being of this person. So we want to keep in mind the natural physiology of what happens when we have the release of these substances, how the body responds to them long-term. That will help us predict the side effects and reason through why we choose the dosing schedule that you would choose and the administration style that you would use. So that is the physiology review. Check the next lecture to learn about the specific medications that mimic these substances from the adrenal cortex so that we can treat things of this nature.